Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant. This podcast is produced by the Institute for the Advancement of Breastfeeding and Lactation Education and is co-sponsored by the Academy of Breastfeeding Medicine. Hi, Karen. How's it going?
Good, Anne. How are you today?
Good. So let's talk about science, specifically.
Yay, science.
Yeah. So I have an article that is entitled Electroencephalographic Activity During Direct Breastfeeding and Breast Milk Expression in Primiparous Mothers. The first author is Perez Hernandez, and this was published in Early Human Development in 2024. So this study evaluated EEGs to describe brain functioning among 18 women who were either breastfeeding or pumping. And they basically just wanted to see, like, what do these brain waves look like when they're breastfeeding versus pumping, which I think is fascinating.
It's so interesting.
Yeah. And, I don't know much about brain waves at all. Like you look at EEG and I'm like, what is going on there? Obviously, you need to be a neurologist to understand that. But apparently there are 5 major brain waves that are associated with different emotional, cognitive, and behavioral situations. So like you've heard of the delta wave and the theta wave and alpha, beta, gamma. I guess it's all the Greek alphabet.
It's all Greek to me.
It's Greek to me too. But these waves actually mean something, and they're associated with like activity of different parts of the brain. So the women had they did EEG recordings of these women in the 2 different situations. So one individual would directly breastfeed for 3 minutes on each side and have her brain waves recorded, and then take a break and then pump from each breast for 3 minutes. So each person underwent both activities. And during breastfeeding, they were told to gaze at their baby's face. And during pumping, they were told to gaze at the pump. So you can imagine the different moods that you would have if you're gazing at your baby or gazing at your pump. After each condition, the participants were also asked to report their mood based on something called a pick-a-mood instrument. Have you ever heard of pick-a-mood?
No, this is fascinating.
Yeah. It's like a visual analog that you would use with kids, like the smiley faces, but it's a visual analog for adults, and they use like these animated people that had like certain mood, like visualizations of like how they would feel or how you would feel when looking at that person. And so, first of all, at baseline, they also, before they even got started, so they asked about the pick-a-mood at the time that they did the intervention. But before they even got started, they did do an Edinburgh postpartum depression scale and found that no one exceeded the moderate depression or anxiety. So people were overall okay. I mean, it's, there's always some degree of depression symptoms and anxiety symptoms among these individuals, among people who are postpartum, because they're tired, So what they found is that for the pick-a-mood instrument, people who breastfed directly were more likely to describe feeling cheerful or calm. No one reported feeling cheerful when they were pumping. They did report that they felt calm, bored, tense, or irritated when they were pumping and staring at their pump.
While we're talking, I Googled the pick-a-mood thing, and it is amusing to me, but you haven't allowed me to screen share, so we can't look at that together and make jokes for the audience. But you guys out there should all just Google pick-a-mood later and see this extremely emotive person making a bunch of different body language expressions.
Yeah, it's funny. But they found that when they look at the pick-a-mood rating that people had during pumping or feeding and compared to the EEG waves, they were definitely in touch with their own feelings, because the EEG waves confirmed how they were feeling. So I think that's fascinating, actually, because sometimes, you wonder, like, do I feel that way or do I not feel that way? But our brains are Can't tell a lie, right?
Oh, I mean, this is like, I have so many questions. Like, were these all neurotypical people? Like, what would happen if we had a, group of parents with autism who were having this time? But anyway, keep going.
Yeah, no, they didn't do that kind of analysis on these individuals. So basically, direct breastfeeding was more likely associated with slow EEG bands um, that sort of supported the report of positive moods during breastfeeding, the feeling of pleasure, calmness, and a cheerful mood. But the other thing is that they looked at brain dominance, right brain versus left brain. Can you guess whether breastfeeding was associated with being left-brained or right-brained?
I would assume right-brained.
Yes, that's exactly right. Is that they found that these people had right brain dominance on their EEG. They interestingly, they didn't say whether it's left brain or right brain during pumping, but they said that other studies have shown that people when they're pumping are right brained.
I
So,
mean, this explains so much about my patient population and why all of these like highly analytical type A people are struggling.
it's really
Okay.
true. Like it's like the right brain people who are just so like intuitive and go with the flow and don't need to be so exact. They do really much better. I mean, that's a really good comment. I totally agree. So that was all about that. But I think we can say that with certainty that there is evidence that when you breastfeed, you are going to feel much better many times a day compared to sitting with your pump.
Wow.
Yeah.
Well, that is really fascinating. I did have a patient recently who is actually an anesthesiologist who came in just a couple weeks after delivery after having had a really rough start. And she was exclusively pumping. And she said to me, I've just come to terms, I'm going to exclusively pump. And she was having some pain. I helped to do a pump fitting and, fix that. And I said to her, you know what? It's, I can respect that. And you're still in this window of the first 2 months when generally we can get babies to breastfeed well. And so if you're wanting to explore that, come back. And so she came back and she brought her baby, and it took a couple of visits, but everything got sorted out and baby's breastfeeding terrific and she's hardly pumping at all. And she's so happy. And she's just
Yeah.
like, I didn't realize I wasn't really bonding the way that I am now. It was really interesting.
Yeah. Yeah. I mean, I think that there are some people who recognize it really early on. They're like, okay, this pumping is destroying me, and I feel like I'm not the real mother of this kid until I just am breastfeeding my kid. Um, and others, just are so focused on the numbers, and maybe they're the left brain people. You know, they
Yeah,
can't
and
believe the drops. They just want to count the drops.
I certainly don't think that that is the case for everyone, but it was really interesting because I could tell she was happier, but it wasn't until she said like, "Oh yeah, I didn't really feel attached, but now I do." Oh, it's
But
kind of
the other
fascinating.
thing is that people who are really focused on pumping, I find that oftentimes with their next baby, they don't want to go through that again. They did find it stressful. Most people, I would say, I mean, there's a small number of people who are happy, who are high producers. They pump 4 times a day. They get plenty of milk, and they're fine with that. But I would say the majority of people who were exclusive pumpers are really excited to have another baby and try over again and see if they can get their baby just to nurse. All right, so it sounds like you have something interesting to discuss.
Yeah, so I mean, I think we've known for quite some time that breastfeeding has an impact on reducing childhood obesity, and evidence continues to accumulate about that. And so I was interested in this new study that came out in January in 2024 in pediatrics, and it's titled Maternal Prepregnancy BMI, Breastfeeding, and Child BMI by Gail Ship and colleagues at Michigan State University. And we know that breastfeeding may protect against offspring obesity, but the relationship is understudied among women with obesity. And so this study analyzed that data, and it came out of the Environmental Influences on Child Health Outcomes study or program, which is called ECHO, that includes 69 pediatric cohorts designed to evaluate the effects of early life environmental exposures on 5 priority outcome areas, including childhood obesity. And the inclusion criteria for this analysis were that, of the data that was available, there was data on these dyads that included pre-pregnancy maternal BMI, infant feeding practices, and at least one child BMI measurement between the ages of 2 and 6 years. What's interesting and special about this study is that it was large. It had more than 8,000 dyads from 21 echo cohorts. It had a lot of diversity in the population. And it found that while duration and exclusivity of breastfeeding varied between groups, specifically groups of mothers with varying weights, there was a underweight group, normal weight, overweight, and obese. Those mothers who were in the obese category had the lowest duration and exclusivity of breastfeeding, with 17 weeks and 12 weeks, respectively. And it showed that breastfeeding for 3 months and exclusive breastfeeding for 3 months were associated with lower rates of childhood obesity for children whose mothers were in the normal weight group, the overweight, and the obese group. This isn't shocking, but I thought that it was interesting. And there are a few things that the author said that I thought were fun to talk about. So obviously there are some limitations on this study. And one of them is a really common one we face in breastfeeding, which is initially when they did the echo cohorts, they didn't have a standardized definition of exclusive breastfeeding. And subsequently, they realized that and they corrected it. So future data, and there are like 69 echo cohorts, will be more consistent. In addition, this relied on some parental reporting of feeding practices. But I think the interesting things about this really had to do with the fact that in this group, almost half, 45%, were in the normal weight group. A little over a quarter were overweight and a quarter were obese. And so it is a huge portion of our population now that is in these categories. And the median age of the BMI measurement of the children was about 3.25 years. About 90% of the children were ever breastfed. So there's a huge number of parents who are initiating breastfeeding. And those numbers were all over 90%, except for the group of obese mothers, where there were only 86% who initiated breastfeeding. And so, yeah, there is a big difference.
Yeah.
And like I said, they had the shortest duration. So there's lots and lots of statistics, but the conclusions of the study were that the prevalence of maternal obesity is increasing, and it appears that due to this, it's going to negatively impact initiation and duration in the future. So the authors highlight the fact that women who are obese should receive additional focused breastfeeding education, addressing breastfeeding related problems, and receive extra assistance from healthcare professionals, given their lower likelihood of breastfeeding success when such supports are not in place. And they also mentioned that although there is evidence of individual variation in breast milk composition, the potential mechanisms and role of these factors in the transmission of obesity risk from mother to child are not understood. And while there's limited literature and some inconsistent results that have sometimes presented the idea that it could be harmful or that milk quality of obese mothers is not as good, these messages are harmful and discouraging to families. And this study shows that those parents, as well as normal weight parents, have children who benefit from breastfeeding in terms of reduced obesity. So it really is an opportunity for healthcare professionals to be reminded to protect women who are trying to breastfeed, especially those who are obese.
Yeah, so I thought, and maybe I'm not remember the right study, but I remember reading that study, and I'm trying to remember if that's a study that also emphasized that we know that people who have a high BMI are more likely to have children with high BMI, and that breastfeeding actually mitigates that risk. It actually can modify that risk, right? So that they're less likely, they're not necessarily given the same sort of genetic sentence, so to speak, if they're breastfed.
Yes, and
Yeah.
I skipped over the part where they said, you know, this there was some study that said that maybe people who are obese, their breast milk has a higher concentration of quote bad fats or inflammatory markers. But we don't that's a lab analysis of milk, and we don't know what the implications are. And this is a patient outcome. It's a much more relevant outcome to us when we're counseling parents about it can be protective.
Yes, absolutely. I mean, there's so many, like, we're just beginning to understand, the mechanism by which there's lower obesity in children, but some of it's microbiome, some of it has to do with just like setting that metabolism in some way, which is beyond me because I went to medical school before we knew what a gene was. But I mean, I look at these studies and I'm like, oh my God, I got to go back and like get a degree in something that has to do with a bench because I don't understand these
Well,
terms. But
and you know, I find this super fascinating. Like I love when I'm teaching the students to say to them, okay, like let's say I have an adult who is overweight or has high cholesterol. If I say to somebody, you have high cholesterol, I'm going to give you a medicine for that, or I want you to stop eating bacon. I can lower their cholesterol, but if they stop taking that medicine and they go back to eating tons of bacon, their cholesterol is going to go right back up. The amazing thing about breastfeeding is these babies were breastfed for 3 months and they had a difference in their weight 6 years later.
exactly. They're set in a total. What I tell families is like, look, your kid's on a different trajectory. If they're breastfed versus formula fed, you're starting them off here. They're going to go down this path. And if you start them here, they're going to go down this path. So where do you, and then they're going to have to work to get to the healthier path. So which way do you want to go? And I try not to say
Yeah.
a bunch of guilt, but
No, and I really think that we can say it in a way that is, you know, supportive of families. Like, you know, people ask me all the time, it's always the people that have like very little milk. They're like, well, how, you know, how bad is it to give formula? And I'm
yeah,
like, you know what? We know that any amount of breastfeeding is beneficial. You have done it. Check. Good job. And if we look at this study, you really get into the statistics, any breastfeeding at 3 months was protective. Exclusive breastfeeding was protective. Any breastfeeding, meaning they only did it in the hospital, was not protective. So, you know, there is some amount that you have to reach,
yeah,
but it isn't exclusive breastfeeding for 6 months and continuing for 2 years. It's dose dependent.
yeah. There's so much that we need to do about counseling for people. There's, oh my gosh, we go on and on about that. Great. Yeah, no, I think that's a really good message for people who have have a high weight that they can actually change, that risk for their infant, and people who have a high weight, they don't want children who are overweight.
Absolutely. And
Yeah,
then the last thing I'll say before I let you go to your next one is just that, you know, the patients who are in the obese category, they mentioned in here they're less likely to be encouraged. They're less likely to have immediate postpartum skin to skin. They're
yes,
more likely to have delayed lactogenesis, breast engorgement because of large breast size. And I think it is not ideal to focus on prenatal education and intention alone. We have to stratify the risk of those patients and make sure that they have support and follow up.
absolutely. I mean, I have to say this, that when I look at my patients in my practice, I don't necessarily see a relationship between body weight and secretory activation and milk production, quite honestly. I see it more in like actual breast hypoplasia, but I've never had a situation where I say to someone who has low milk production, where I've said, well, I've ruled out everything else and it must be your weight. Like I've never done that. I've never found that to be the case among my patients. It's usually, more associated with the consequences, right, of having like, the other markers, like preeclampsia, gestational hypertension, gestational diabetes,
Diabetes.
right? Because not everyone with a high BMI, first of all, BMI, we know more and more, may not reflect, lean body mass, right? Um, and also, I mean, I've had patients who are 400 pounds who never have diabetes. Their cholesterol's phenomenal. Like they just don't have those genetics. And so, and then I have some, like I have, young patients who are lean, they're athletic, but they have high blood pressure and high cholesterol, and they have delayed inhibitory activation. So, I mean, I think it's more the metabolics, the total metabolic score, and not just the BMI. So I think that's that whole, like what you're talking about, that implicit bias, like, oh, that person's like way over it, they're not gonna breastfeed. We have to get beyond that, and we just need to make sure that we're, not making any kind of judgment on what people are going to do. So
Absolutely. You're right.
yeah. So I love maternal physiology, and I love, reading about like the way that our bodies are different with lactation, what lactation does to the, to the adult body. So I've always been interested in like bone density, maybe because I'm of that age where I should watch out and make sure I don't fall. But anyway, this was a study that is entitled Lumbar Spine Bone Mineral Density in Women Breastfeeding for a Period of 4 to 6 Months, a Systematic Review and Meta-Analysis. And this was published in the International Breastfeeding Journal in 2023. The first author is Larissa Ferreira, and others. So what interested me about this study is to understand what really is happening with that bone density from the time that people become pregnant to when they wean, and when does bone density reach its like nadir, like the lowest, like the most loss, and then when does it recover? So this systematic review sought just, officially to determine the occurrence, intensity, and factors associated with changes in mineral bone density during 4 to 6 months of exclusive breastfeeding. So they found 16 articles that they could use for their systematic review. And then for the meta-analysis, when they put data together, they found 4 studies. So the studies showed that there was a decrease in bone density of the lumbar spine in the first 4 to 6 months postpartum among those who were exclusively breastfeeding, when they compared their bone density to people who are still breastfeeding between 12 and 18 months. So in other words, that bone density, kind of declines, and then by 4 to 6 months, it's the lowest. And then by 12 to 18 months, it's actually looking pretty good. Now, most of the studies did look at the lumbar spine rather than the hip or femur, but that's really where there's more bone loss, which I've always wondered, like, why is there more bone loss in the lumbar spine than in like axial spine, right? So, I mean, the peripheral spine. So in peripheral bones, like in the wrist and in the femur. And I've oftentimes wondered, like, just evolutionarily, why is that? So I wonder if it's because if you have osteoporosis of your spine, you're not as likely to be unable to carry your child than if you break a hip or break an arm. So maybe it's like a way to, it's the safest place for the body to grab calcium from, because the body takes calcium from the bones to put that calcium into the milk for the infant's, growth and survival. So where is it safest to like risk those bones? And maybe that's in the spine. That I just kind of this way, I think. Okay, so they found that the bone mineral density starts to recover at 6 months, and largely because there's less intense breastfeeding, so there's less, like drawing of calcium from the bones. And that's, because babies are starting solids and they're starting to nurse less often. The other thing is that bone density does begin its decline during pregnancy, which is why there is this, we know about this condition called pregnancy and lactation associated osteoporosis. So that's why sometimes we do see people who have osteoporosis and bone and like fragility fractures during their pregnancy already, even before they start to lactate.
Well, and I wonder in this, if you're looking at somebody who is, you said it's improving by 12 to 18 months, like there are a ton of people who have gotten their menses back. And so they're having that estrogen again, they're having those cycle. And that, like, how does it differ in some, like, gosh, those poor gals that get their period back 6 weeks after they deliver, even though they're fully breastfeeding, and
Right.
some of them don't have a problem maintaining production and they keep breastfeeding the whole time. Like, how does their bone density differ from the person like me who managed to not get a period for 10 months? I
Yeah,
felt very fortunate.
my guess is that they actually don't have as much bone loss, because they have this increased estradiol. We know that estradiol levels are, they go up when people start to menstruate again, and estradiol is protective. And that's
Yeah,
uh, yeah.
I just think of that in terms of like this patient that I had not that long ago who had a pathologic fracture. And so then they were talking about like, oh, you should wean at this point. And like, really, maybe if we just, you know, help her to get her cycle back, if she maintains some milk, she will improve her bone health without intentionally weaning.
Yeah. Oh, yeah. My recommendation for that is to give the birth control pill with estrogen.
Hmm. Yeah.
As long as they're not a contraindication and they're past 6 weeks postpartum, which of course it should be, so they have a drop in production, but it's kind of the best of two worlds, right? They can still breastfeed. They might have a drop in production. Not everyone does, but at least they're going to have some bone protection from that. So I really
Right.
think we should be talking about doing that.
But that's exactly my point. Like that is like the breastfeeding centric way to treat versus the person who says, I want to give you this medicine that's not safe with lactation. So please wean so we can start it.
Yeah, and we just get out of the situation so you can get your bone density back. I mean, every single article that I have on pregnancy lactation associated osteoporosis says to wean and to give these meds for bone density. Well, all you have to do is give them the birth control pill and they'll be fine. So, I mean, that's something that I wish that we could do, that we did some studies on for, or at least a case to see what.
Yeah, no, we should definitely do some studies on that. There are enough older parents now who are
Yeah.
lactating.
Yes, and bone density already starts dropping in people's 30s. And so people who do have pregnancy in their 40s, you wonder, like, I don't know that data, but I wonder if that data is out there. So anyway, I wanted to say, though, that bone density does decline during pregnancy, but by 15 days postpartum, there's already a drop of bone density by 2 or 3% from the pre-pregnancy baseline. So it's already significantly down at 2 weeks. And then it reaches its nadir, like its lowest bone density at around 4 months, where it's at 5% loss, which is a lot of bone loss. And then at 9 months, it's back up to like it's 2% less than baseline at 9 months. And then by 18 months, most women, even if they're breastfeeding, have regained all of their bone density already. So, and then just as an aside, they mentioned that studies that have looked at adding calcium have not necessarily shown any kind of protection from that bone density loss. And vitamin D as well, taking these supplements is not going to mitigate the bone density loss. So there you have it in a nutshell. Bone marrow.
Okay, that was fascinating. And now we're going to turn to ABM's newest position statement, which is on paid maternity leave and its importance to society, breastfeeding, and sustainable development. So I'm not going to go through every nitty gritty detail of this, but I really wanted to make sure that everybody listening knew that this new position statement just came out in early 2024. And it has some exciting recommendations for it that hopefully will influence policy around the world in the coming years. And so I'm just going to go through the abstract, a few of the key recommendations, and then we're going to play a fun guessing game about who has the best leave policy, which countries.
Oh, good.
So as background, I'm turning our podcast into a quiz show today. Paid maternity leave benefits all of society, reducing infant mortality and providing economic gain. It is endorsed by international treaties. Paid maternity leave is important for breastfeeding, bonding, and recovery from childbirth. Not all mothers have access to adequate paid maternity leave. So, paid leave helps meet several of the 17 United Nations Sustainable Development Goals, including fostering economic growth. A family's expenses will rise, of course, with the arrival of an infant, and paid leave is often granted with partial pay. Many low wage workers earn barely enough to meet their needs and are unable to take advantage of paid leave. Undocumented immigrants and self employed persons, including those engaging in informal work, are often omitted from maternity leave programs. Thus, recommendations include 6 months of paid leave at 100% pay or cash equivalent should be available to mothers regardless of income, employment, or immigration status. At the very minimum, 18 weeks of fully paid leave should be granted. Partial pay for low-wage workers is insufficient. Leave and work arrangements should be flexible whenever possible. Longer flexible leave for parents of sick and preterm infants is essential. Providing adequate leave for partners has multiple benefits. Increasing minimum wages can help families utilize paid leave. Cash benefits per birth can help informal workers and undocumented mothers afford to take leave. And equitable paid maternity leave must be primarily provided by governments and cannot be accomplished by employers alone. So I thought that was a excellent position to take.
Yeah.
Obviously, I think some countries are doing better than others, but in the document, it goes through, a lot of the research and the literature around this, and then it has 10 key recommendations. Number one is mothers should not be forced to stop breastfeeding because they must return to work. Two, they should not have to choose between working and being with their critically ill newborns and providing them with breast milk essential to their health and growth. I think, we all have known parents who delivered a preterm baby and chose to go back to work immediately so that they could conserve their leave for when that baby came home from the NICU.
Yes.
And that's a really hard choice to make.
Yeah.
As mentioned before, ABM recommends 6 months, that's 26 weeks of leave with 100% pay, and urges the WHO to advocate for this measure in UN agencies, including the ILO. Pay should be provided by the government, not employers, and at the very least, ABM recommends legislation allowing leave of 18 weeks per birth with 100% pay. Paid leave should be flexible and holistic, accounting for varying circumstances. Parental leave may be best viewed as part of a package of paid leave across the lifespan, as most adults will require paid leave at some point to recover from illness, surgery, or care for a sick and dying loved one. One-time payments to families per registered birth, regardless of immigration or employment status, may help to provide a safety net. Workplace accommodations should be as flexible as possible, allowing for part-time work, working from home, outside childcare, babies at work policies, in addition to break time and space for expressing breast milk. Minimum wage workers should be sufficient to relieve minimum wage structures should be sufficient to relieve the strain on parents, alleviating the need to work long hours. Providing equitable paid maternity leave must be primarily accomplished by governments, and maternity leave, workplace accommodation for breastfeeding breaks and milk expression, childcare, and flexible working and parental leave options should all support the WHO recommendation for exclusive breastfeeding for 6 months with continued breastfeeding for 2 years and beyond. So I was impressed. I thought they made some good, I think it's important to spell out the ideal and the reasons for it. I think I particularly have this in mind because when the AAP recommendation changed to encourage breastfeeding for longer, I think some people got up in arms saying, oh, it's too much pressure on mothers to breastfeed longer. And I think people fail to recognize that the goal of a position or policy statement like this is to push our institutions to support families so that parents have the support. We're not pushing the families.
Yes, that's the thing, is that the support that's exactly right. Because they'll say, well, how can I do that? Right. Going back to work and all the things. And can you just clarify one thing? So you talked about 18 weeks and then you talked about 26 months.
Oh, 26 weeks is 6 months.
26 weeks and 20, what is it?
26 weeks is the week equivalent of 6 months.
6 months. Okay.
And so I think there was some internal debate about this document. We look at all the evidence and we see that there's fantastic evidence for 6 months. And I think we also recognize that some people, when they hear 6 months, are like, those people are dreamers.
Mhm.
We're not going to do that. And so saying the minimum leave should be 18 weeks was a way to sort of help officials to recognize that. I mean, especially here in the United States, we're not meeting the bar. We can't even see the bar from where we are.
Right.
And
Right.
that is, it's kind of amazing to me that a number of years ago, the military, starting with the US Navy, advocated for 18 weeks of leave. And, it's not necessarily the most female friendly workplace. Having been in the military myself, I will say I was a little bit surprised and happy about that. And here in Washington, D.C. area, I take care of a ton of patients who work for the federal government, and they actually have potentially really good leave. And they have this great system where there's like shared leave where people donate to each other. And so a
Oh,
lot of those
nice.
folks
Wow.
actually have great leave. But in the healthcare system, I talk to residents all the time who, like have 2 weeks of leave, or the
Yeah.
teachers around here, or some of them have 2 or 4 weeks of leave. And this is why it really needs to be at the government level.
Yeah, there was a study that was published, I think it was last year, looking at the association between state leave policies that are placed upon the businesses in their states and some state funded leaves. Like there's all kinds of different ways that states do this. Some actually just give you money, like California, and others have rules for that the companies need to abide by. But the states that had like the best policies that protect lactating families they had higher breastfeeding rates than the ones that had like no policies. So I mean, I think right there, I mean, we have evidence that it makes a big difference.
Yeah,
Yeah.
absolutely. There's great evidence. And if people are wanting to, find those articles, the references for this position statement have that in there.
It's great.
So, what is your guess as to a country or two that might have a longer length of maternity leave available to their citizens?
I'm gonna guess two countries, Sweden and Canada.
So, interestingly, in this, actually, Sweden is not listed, so I cannot say that, but I will say Canada, the paid parental leave that is listed here is 16 weeks with percentage of wages paid 47.7% and an additional optional leave of 35 weeks. So, and then that is with 52%. So they
Wow.
do have a
Hmm.
longer one. Interestingly, Norway, so close to Sweden, has 18 weeks paid at 96%, an
Wow.
additional 68 weeks at 33%.
Wow. That's amazing. What a great.
Um,
And do they have their kids sleep in the fresh air?
okay, next question. Guess a country that you might think has excellent paternity leave.
I was gonna ask you about that. Did they address paternity leave in this? They did.
Yes, there is some, and there's great data on the economic benefits and the benefits to families of paternity and other spousal leave that is not for the birthing parent. But Japan offers paternity leave of 52 weeks, so 1 year at 60%.
Whoa. I was gonna guess it was Google.
No, we're
It's
guessing
not a country, but
countries.
it's big enough to be a country.
Capital One, actually, the company, Capital One, has 6 months um, spousal leave, I believe.
Wow. Wow.
I've had some of those patients here. I meet them in the hospital and I say, "Where do you work?" And they say Capital One. And I'm like, "Oh, that is excellent. I heard you're going to have some great leave opportunities."
Yeah, it's so
And they're really,
sad.
really happy and really loyal to their company as a result.
Well, that's just it, right? That's really awesome. Yeah. Well, I hope we can get, the more we talk about it, I hope we can get more momentum. It's definitely being talked about at the national level here. Is it Warren or who's the one who brought that up again? Just recently, someone brought it up again. I can't remember.
And
Okay.
just as a last one, I wanted to mention that Democratic Republic of Congo has 14 weeks of leave at 100%.
Wow.
And the
Wonderful.
United States has 0.
0. I know. We're behind in many ways. We work ourselves to the bone. That's for sure. All right. Well, thank you for sharing that. So I think our last thing that we're going to talk about today is cannabis. And I want to review a narrative review. The title is Maternal Cannabis Use During Lactation and Potential Effects on Human Milk Composition and Production. And the first author is Castro Navarro. And this was published in Advances in Nutrition in February of 2024. I thought this was just kind of a nice summary of what we know so far about the effect of cannabis on milk production and composition, and also just like some endocrine effects of cannabis. So THC, as most people know, is the major psychoactive cannabinoid, and its potency, as we all know, has increased by more than 10% in the last few decades. So in other words, it's not your grandma's pot anymore. Which, I've heard many times.
I've heard that.
True.
I've heard that. I can't speak to it personally, but I've heard that.
Yes. But there are actually 125 cannabinoids that have been isolated from cannabis sativa. So cannabidiol is the CBD oil, is the other really most abundant cannabinoid that has been studied and used clinically, right? Because it doesn't have those psychoactive effects, and it's used like for pain and for inflammatory conditions and emotional conditions as well.
Wait, I have a legitimate question about that.
Okay.
So I've heard that said before, but I also don't entirely understand how we can say that CBD doesn't have psychoactive effects if it's affecting pain and emotion. Like they're
Yeah.
not the same psychoactive effects,
Yeah.
but it's got
Right.
some.
Yeah. Yeah. No, you're right. I agree. I mean, it definitely, people feel calmer, they have less pain. So maybe it doesn't cause as much maybe dysfunctional psychoactive effect.
It's fine. I just wanted to clarify because I did have a patient recently who was like, "Can I do this?" And I was like, I mean, here's the evidence for it, but I think people have gotten it in their heads that it's like because we were all taught in high school, THC is
Yes,
the
that's
thing.
corrective. Yeah. 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 So cannabis use during pregnancy has increased from a rate of 3.4% in 2002 to 7% in 2017, with most of the use in the first trimester. And the perception of risk of using cannabis during pregnancy has declined. And in fact, some dispensaries are actually advising women that it's safe to use cannabis during pregnancy for nausea. They found that reasons for people to use cannabis during lactation include anxiety, depression, GI problems, pain, and PTSD, post-traumatic stress disorder. In terms of effects of cannabis during pregnancy, there's an association with low birth weight, premature birth, and higher NICU admit rates, with poorer performances later on in infants and children in verbal activities, short-term memory, and attention. But there's not as much research in lactation, and it's hard to tease out the effect during lactation because a lot of these people were using cannabis during pregnancy.
So
So
true.
a little bit about the physiology. So we always talk about, oh, cannabis is stored in the body fat, and so it's just going to hang there. Well, that's in fact what they do say in this review, is that adipose tissue is the long-term accumulation depot for cannabinoids. And the THC actually forms these fatty acid conjugates, which allows them to remain stable in fat. And so the ratio of adipose to plasma, THC, can be as high as 104 to 1. Like it's super saturated and just kind of clings and kind of sits in fat. And in fact, what they were saying is that if someone who has a fair amount of THC in their adipose tissue, if they exercise, they actually spill a fair amount of that. As they catabolize that fat, they actually spill THC into their plasma.
So then when you get a runner's high, it means something
Yes,
else.
it's truly a runner's high. The more you've been accumulating that THC, the more benefit you get, I guess, when you start running. Although you might end up running in a direction that you didn't mean to. So THC actually does easily go into breast milk because of its lipid solubility, and it's also a small molecular weight, so it's easier to get in. So one thing I didn't know that I learned in this review is that once the THC is in the milk, it gets partially ionized, which prevents it from getting back into the maternal plasma. So usually we think about meds as diffusing from, sort of like passively from the plasma to the milk, and then as the plasma level goes down, the milk level goes down, but that's not true for THC. It actually accumulates.
Yeah. Like we say that all the time for alcohol. It's in equilibrium. It goes back and forth. When you're not feeling tipsy anymore, it's gone out of your milk.
Exactly. But this actually, because of the ionization, it doesn't go back into the plasma. So what ends up happening is that for a lot of people, their milk level will be greater than the plasma level. And the more that they are using cannabis, whether they're inhaling it or whether or not they're ingesting it, they can see this really gradual rise in that concentration of THC in their milk over the course of months. So then you think, oh, I've been using, someone may say, well, I've been using cannabis for a long time, but now my baby's, 6 or 8 months. So the exposure is not as big of a deal, but in fact, they may be exposing their baby to a higher concentration of THC in their milk over time. There was one study that showed that the milk to plasma ratio can be as high as 8 to 1 of THC.
I read that study and it was an N of 1. And it
That
wasn't a
was
very good study. Or N
no,
of
that was the
2.
CBD. Oh, you mean one person had it? You mean just one person?
There's one like really hyped study of
Yeah.
marijuana where they were like, and the milk level was 8 times that of the serum level, and it was 1 or 2 samples. It was a very, very small number.
Yeah, but I know that study too. It did show that the THC was hanging around in the milk for a long time. That was for sure impressive. So again, because THC is stored in adipose tissue, it can gradually get released from the body fat, as that's catabolized and end up in the milk. And then that actually will add to the amount of cannabis that ends up in the milk, even after weeks of abstinence, because it's still spilling into there. So the other thing is that there are receptors, right, for cannabinoids, that allows THC and CBD to affect our brains. So that's called the endocannabinoid system of receptors. And these receptors are also in the mammary tissue. And so THC does have an effect on different metabolic, has different metabolic effects on milk, actually. And this is just starting to be studied, and this work has largely been in animals. But they have found that activating these receptors will affect the milk fatty acid profiles and protein synthesis in breast milk. In addition to its effect in the mammary tissue, THC and other cannabinoids can interact with the dopaminergic system. So in rats, what they found is when the rat was exposed to THC, they had a brief rise in their prolactin, and then there was this prolonged decrease in prolactin. And so what happens is that first, it seems like there's an increase in prolactin secretion on activation of that endocannabinoid receptor system in the pituitary. But then, because THC activates a dopamine release, you get this gradual decline in prolactin. So that is something to be thinking about as to whether or not it can be associated with decrease in milk production. So the thing is that there are a couple studies done in humans so the studies on the effect of THC on human prolactin levels are actually conflicting. And these were done in non-lactating women. So, pituitary prolactin secretion is different. The control of that is different during lactation than non-during lactation. So it may not be relevant, but it seems that prolactin does not change after acute exposure, but with long-term use. In one study, prolactin was found to be lower after that long-term use, whereas another study of chronic use didn't see that. So we don't know that for sure. Another study looked at the effect of cannabis on milk production and found that a group of lactating women found a decrease in production with cannabis. However, a third of those women were using tobacco. And we know that that cigarette use or tobacco use can also reduce milk production. So it was hard to tease out for them. But essentially, I think the big takeaway here in what they're talking about is that THC stimulates the reward system, which is increasing dopamine, right? That's the whole thing, is like increasing the dopamine is what's great. But then if you increase dopamine, you reduce prolactin. So that's not necessarily a great thing. And then one other thing I want to talk about is oxytocin, because one study looked at milk ejection reflex in lactating rats after giving them IV THC versus placebo. And they found in the placebo group, the time interval between two milk ejection reflexes was about 6.5 to 7 minutes. But when they gave them the THC, from the first to the second milk ejection reflex, it was 59 minutes. So that's the other thing, is that, the bottom line is that cannabis can affect prolactin secretion by affecting dopamine, and it might affect milk ejection, and it might also affect milk composition. It definitely accumulates in breast milk. And we also still don't understand the effect on the development of the child, and separating that out from exposure during pregnancy. But, it makes me think about this milk ejection thing, because sometimes I see people who will say, it takes so long to get my milk ejection reflex. And I'm not really great at screening people for cannabis use. I don't know if you are, but I wonder, now I realize I should probably, this is like the third time I've said this to myself, like, you've got to start asking this question, because I wonder if that could be associated.
Yeah, it's interesting. I will say I do, I probably could do a better job screening. And I also find there are some people who have a hard time with that. And the majority of those, it's with pumping. And a lot of times that's because they're more aware of it when they're pumping. But I also realized a while ago that sometimes you see those people that they're like, oh, yeah, I start to pump and milk comes out of this side, but it takes 8 minutes for it to come out of this side. And I was
Right.
like thinking to myself, well, your hormones hit the breasts at the same time.
Exactly.
So it's not that. And then I realized sometimes that happens in people who have a lot of areolar edema, and it's compressing the ducts and it's making it harder for the milk to come out. And so then I started to pay attention to some of the people that complain about that bilaterally. They also have a lot of edema. So I think I would make sure I excluded that first before I thought it was a hormonal problem. And it goes to this, like, we all want to fix it. And people come in and they're like, I have a hard time letting down with the pump. Can I get this oxytocin nasal spray I've read about? And you and I know that isn't a good idea, because then people, can't let down without it after a few doses. But I think the pumps that people are using and the ways they are using them are also leading to a lot of those issues.
Yeah, no, I totally agree. But sometimes I see people who, were letting down fine to the pump. And, granted, sometimes it's anxiety or whatever. And sometimes I'll get calls from people who are like, oh, I'm directly nursing my baby 100%. And now at bedtime, I can't get a letdown and my baby's getting frustrated. And they get into that anxiety cycle, right? Where they worry that their baby's going to get fussy, that they can't let down, and then they can't let down because they're anxious. And, it just kind of swirls. But I do think that there are these times where people will say, my letdown is so much slower than it used to. And I think it's just something that we should, think about. I always think about, anxiety and thyroid disease, but
that should be on the list for sure.
And then alcohol, of course, we know can do that. And then asking about cannabis is a good idea.
Yeah.
So
Yeah. And it's just hard for people to tell. I mean, some people are so in tune and they can really like hear swallowing or notice how the baby's drinking. And then there are a lot of people who really are not in touch with whether or not the baby is transferring.
yeah,
And I'm sure you've seen this thing where, people experience the feeling of letdown much more when they have a higher volume of milk
right,
than when they
right,
have a lower volume.
right.
And I think that's because, like, what actually is that feeling? Why do we have this feeling of like pins and needles or electricity or, the interesting ways that people describe it? And I think that it's really a matter of stretch on all
Yeah,
those little tubules. Like
yeah,
you're getting all this milk pushed down and all those little tubules are stretching. The more milk you have, the more stretch you get. And
yeah,
so,
yeah. That's what I think too. I think it's just, yeah, people generally feel it with that first heavy letdown. Yeah.
mhm.
Yeah, no, yeah, for sure.
That
So
was really fun. You had such a variety of interesting articles. Thank you.
yeah,
Thank you.
that's what we got for today. I hope people find it interesting, and we'll be back again with
Yes.
more.
Thanks, Anne.
Yeah, talk to you later. Bye. For questions regarding this podcast, please contact us through our website at lacted.org. We have other educational projects, including the Clinical Question of the Week, our Little Green Book of Breastfeeding Management for Physicians, and our various educational courses and conferences for physicians and other breastfeeding supporters. If you want to see what we look like, check out our Breastfeeding Medicine podcast Facebook page, where you can post any questions or comments about our podcasts. Thanks for listening, and we'll be back with you in about 4 weeks.